I'd also like to take the opportunity to thank SIO and CCMA for the opportunity to speak and meet with you today. And certainly the sponsorships by ECO as well as Certex help us share our experiences with some of these therapies. As Professor Madoff had described, I'm based in Vancouver, British Columbia, Canada. We have a very large Chinese population, and as a result, the majority of our embolization therapies involve HCC. I'd like to share with you our experiences using radioembolization, also known as selective internal radiation therapy, or SIRT therapy, in the treatment of HCC, and how we've incorporated it into our practice, which includes microwave ablation, radiofrequency ablation, TACE, DEB-TACE, as well as the other modalities that you're familiar with. These are my disclosures. So in the next 25 minutes, I'd like to introduce you to the concept of SIRT and initially compare SIRT to TACE, which many of you are familiar with and is available to you. And then from there, launch into a discussion of the clinical settings, the evidence, and some case examples, in particular in these situations: downstage to cure, which includes ablation, surgical resection, or transplant, the concept of radiation segmentectomy, as well as the presence of PVTT or portal vein thrombosis. Before we begin our discussion about the clinical use of Y90, I'd like to go over some of the differences that exist between Y90 and conventional TACE. And by conventional TACE, I'm describing both DEB TACE, so drug-eluting bead TACE, as well as Lipiodol-based TACE. And in the Western literature, this is referred to as C-TACE.
I'm in a conference call.
When we talk about radioembolization, the radioisotope or radioactive material is Y90, ethylene. And Y90 is a unstable radioisotope or radiation source that actually will, when it decays, break down or decay into zirconium-90, and at the same time emit what's called a beta particle. And this beta particle, or this beta fossa, is actually just an electron that's emitted as this yttrium-90 breaks down into zirconium. And this is the entire basis of the treatment. So the microsphere, or the particle that the radiation is actually placed on, has nothing to do with the treatment itself. And we know this because the design of the microparticle is in the 20 to 70 micrometer range. When we perform DEB TACE, we are actually occluding or blocking the inflow arterial vessels, but very little or very few of the particles actually penetrate into the tumor itself. With resin microspheres and with Y90 radioembolization, the particles are much smaller, and as a result, they actually penetrate into the tumor. A very important fact, because we do not really see true embolization, angiographic embolization, because the SIRT particles penetrate into the tumor rather than surround the tumor. A study by the group in Pamplona demonstrates and confirms this. What they had done is performed embolization with the particles that have no radiation in them in pig livers to the point of complete stasis, and then surgically remove the livers and examine them under the microscope. And at 2 months, the particles themselves are identified. However, there is no evidence of necrosis or embolic necrosis. You can see that the tissue is still very well maintained. And what that tells us is that all of the radiographic findings that we see associated with SIRT therapy is due to the radiation itself. Other clinical studies in humans demonstrating the particle distribution within the tumors have been well established as the basis of treatment. So in this example by Andy Kennedy in 2004, a patient that has been treated with SIRT has had their tumors removed, and what you can see are the little black dots here, which represent individual radioactive particles implanting directly into the tumor. This is important because it also helps describe why some of the response in Y90 or in SIRT is so deep and so profound. Tumors shrink more after Y90 as compared to TACE or DEB TACE, and tumors have a tendency to take longer to progress, so the time to progression is substantially increased. In this study by the Piedmont Group in Atlanta, Georgia, headed by Professor Arvind Arapalli, what they had done was looked at patients with HCC explanted tumors and compared SIRT resin microspheres with drug-eluting beads to take a look to see which tumors actually responded better. In their paradigm, what they had demonstrated was that when patients were undergoing DEB TACE, that there was a significant amount of residual disease. So for instance, in this one patient who demonstrates a very nice radiographic response, there's still evidence of recurrence of disease, and there was only reported 80% necrosis. Similarly, for those patients that had received Y90, you can see a very nice radiographic response with further shrinkage of the tumor, with the explant or removal of the tumor revealing 90% necrosis. In their study, when they compared the frequency of complete pathological necrosis, in other words, when looking at a slide, how many patients had complete necrosis of their tumors, you can see that there was a substantial difference between Y90 versus DEB TACE. Almost 70% of patients who had received Y90 had actually had complete necrosis of their tumor, as compared to only 21% of patients who had received DEB TACE. So a very statistically significant difference. This describes why tumors shrink more with Y90. It also describes why when tumors shrink, it takes longer for the tumors to begin to grow, because the incidence of complete pathological necrosis is greater, and therefore many of the lesions themselves have actually been completely cured with Y90. So when we take a look at the literature and we understand these mechanisms, we can take four very important facts to understand the clinical results. SIRT is not an embolic therapy. It is not the same as DEB TACE. It is not the same as CTACE. SIRT provides better and deeper imaging response, which we will see very shortly. SIRT is fundamentally different than DEB TACE and Lopidol TACE. And the number of spheres and the amount of radioactivity permits different techniques of use, which I will go into very briefly. At this point, I'd like to describe some of the clinical literature and some of the ways that we use SIRT therapy alongside with DEB TACE and alongside with our ablation platforms, which include predominantly microwave, but also radiofrequency ablation. There are a number of articles that demonstrate that the use of SIRT therapy in primary liver cancers can help increase the chance of resection for complex lesions, increase the chance for ablation because the tumors will shrink down more, and therefore the ablation or thermal ablation zone is significantly smaller, or in specific cases, techniques such as radiation lobectomy and radiation segmentectomy, which I'll describe shortly, have allowed for patients to receive a cure as opposed to palliative measures, which most embolotherapies are really designed to do. The first question that one has to ask is whether we can, even though we can see a shrinkage of tumors after a treatment with SIRT therapy, is it actually safe to operate on these patients? And in the Annals of Surgical Oncology, the P4S study, which was headed by Fernando Pardo in Pamplona, helped answer this question. In this retrospective analysis, they took a look at patients with 100 unresectable liver tumors that ended up getting a liver resection. They identified 71 patients that received liver resection, and then divided it into the number of segments that were resected, breaking up into minor resection, which is 2 Cuinard segments, versus major resection, which was anywhere from 3 to 6 segments surgically resected. And they looked at the mortality rate and the complication rate associated with these patients that had first received SIRT and then received surgery. So the most important table here, or the most important area to look at is here. And what we can see is in cases where there are only 2 segments resected, there was no mortality event. In situations where there were 4 segments resected, there were no mortality events. And only in cases when there was an extended hepatectomy, in other words, more than 4 segments resected, so 5 or 6 segments resected, did they actually end up having a statistically significant increased complication rate. This increased complication rate, mortality or death at 90 days, really doesn't represent a significant difference as compared to if these patients had had a resection without SIRT. So their conclusion was that no deaths appear to be directly related to SIRT. So with this type of therapy, what we can do is transform patients that are non-resectable and non-curable to a potential curative intent, with an understanding that even in these situations, as without SIRT, extended hepatectomies have an increased complication rate. Furthermore, Fernando Pardo investigated those patients that had received a surgical curative intent, meaning resection or transplantation, from original presentation of patients that could not receive surgery or curative intent. And what he had demonstrated, his group had demonstrated, was that for those patients that could receive curative intent after SIRT, that the survival was markedly improved as compared to those patients that could not receive curative intent. So the SIRT therapy increases the chance of a person's survival if they're able to receive a cure after receiving therapy. Here's an example of a downstage patient. This is an individual with an HCC. As you can see, portal hypertension. The HCC is in a very difficult spot, not ablatable, difficult for surgical resection, 6 centimeters in size, portal hypertension, and Child's Pugh B. This patient had received treatment in a technique that I'll describe later on called a radiation segmentektomy, where the intent is to give a very high amount of radiation in order to eliminate as much of the tumor as possible to allow for shrinkage and therefore allow this patient to receive a transplant. And what we can see in 3 months later is that the lesion went from 6 centimeters, 5.5 centimeters to complete shrinkage with no hypervascularity. And as a result, the patient was able to downstage to transplant. There was microinvasion on pathology on the initial biopsy, but on the surgical resection on the explant liver, there was complete pathological necrosis, and they're 7 years out with routine follow-up in a transplant clinic. So as I mentioned before, there are different techniques that we can use with Y90 or SIRT therapy, and I'd like to describe some of these techniques. The first approach that I'd like to describe is referred to as a conventional approach. And in the conventional approach, the target is actually the tumor itself. So when we calculate out the radiation dose, in other words, when we calculate out the TVM, we are actually calculating out how much we're giving to the tumor. After this, we want to ensure that the radiation does not leak into the radiation that leaks into the lungs is not dangerous. And then finally, we calculate out how much radiation is going into the adjacent liver to prevent the liver from actually receiving damage from the radiation itself. Because unlike CTACE or DEBTACE, the radiation that goes into the tumor can actually cause substantial damage to the liver. So we have to make sure that we optimize or calculate out the amount of radiation that goes into the liver and the tumor. So this is an example of a conventional approach treatment. You can see very large, difficult central lesion. Post-implantation of Y90, this time or with SIRT of 0.8 gigabecquerel, which is kind of considered the amount of activity or the dose. And you can see here at 3 months, a fairly good response with some residual vascular disease, as well as radiation-induced damage. This, of course, we were able to consolidate with microwave ablation directly adjacent to the IVC. In a different approach, where we just use a different amount of radiation, a different TLM, we can perform what's referred to as a radiation segmentectomy. And in a radiation segmentectomy, what we are actually doing is we are targeting the liver and understanding that there is going to be a lot of radiation that goes into the tumor, but we kind of ignore that. What we actually do is we target the dose to the liver so that this entire segment will then subsequently undergo damage and close down. This is actually useful for lesions that are very difficult to describe in a single segment. In other words, infiltrative disease, microvascular invasion, or multicentric disease, or as you'll see with portal vein thrombosis or invasion of the tumor into the meningi. So what we do is we target the liver segment at 70 gray, and then we confirm the safety margin for the lungs. This is an example of a radiation segmentectomy. So as you can see, segment 2, very well-defined peripheral lesion adjacent to the stomach, very difficult to treat without hydrodissection and very large for microwave ablation. You can see that the vascular pedicle defines a very discrete hypervascular tumor. And after we perform the radiation segmentectomy, you can see that there's complete response and no metabolic activity. And in this case, as you can see, what we did was we targeted the adjacent liver in order to be able to address the margin of the tumor, realizing that the amount of radiation that the tumor will receive is going to be significant. Finally, in a radiation lobectomy approach, it's a very similar approach to the segmentectomy that I previously described, only in this case, what we're doing is we're going to be targeting a lobe of the liver. We have to ensure that the patient has enough hepatic reserve for the contralateral lobe to compensate, but essentially the same approach. We target the liver and then we confirm a safe margin for the lung. Here's an example of a patient who had HCC with a previous mesohepatectomy, so segment 4 resection, and multicentric disease within the lobe, but a clear margin in the left lobe. They had received a radiation lobectomy approach, targeting the liver at 70 gray, a total of 2.0 gigabecquerel. This is the post-implantation, and what you can see at 3 months is retraction of the area. The increased attenuation from the arterial phase is from the radiation response, but you can see that the lobe itself is shrinking dramatically. So very similar in approach to a surgical resection. So when we talk about the two different techniques, the one technique that cannot be done with TACE is this segmentectomy lobectomy approach. And what we actually do is effectively ablate or irradiate the segment or the lobe of the liver with the intent of completely destroying all tissue, not reserving any liver. As then to protect first, really trying to irradiate the entire liver with a lobectomy approach. So one particular area of large tumors that we found that this is very effective for is for portal vein tumor thrombus involvement. If we take a look at the previous literature, we can see that with patients patent versus branch versus main or main branch, which you can see here delineated as green, blue, and red, that those patients with main portal vein occlusion have a lower survival as compared to those with patency of the portal vein. As we know, the presence of tumor within the portal vein is a poor indication of survival. Patients do not survive as long. So this has led to much investigation into what's referred to as macrovascular invasion or portal vein invasion, also known as PVTT, portal vein tumor thrombus. In our work in Vancouver, we've actually looked at different techniques of radiation of SIRT therapy and have demonstrated the following. When the radiation lobectomy or segmentectomy approach is applied as compared to conventional radioembolization, we actually see a doubling of median overall survival. So for a patient with PVTT or tumor invasion, their survival is 3.5 years. Median survival is 3.5 years as compared to normal or conventional treatment. And for those of you that have looked at the literature of PVTT or portal vein tumor invasion, there is no other therapy in the published literature that demonstrates 3.5 years of median survival. And this is just on a basis of the radiation lobectomy approach versus the conventional Y90 approach. So 3.5 years. This is better than systemic therapy. This is better than SBRT, and also better than the TACE published literature. This is an example of a radiation lobectomy. So you can see here on initial presentation, branch or segmental portal vein invasion. You can see the tumor defined here, post SIRT therapy, and 3 months post. You can see here very clearly that the tumor has become devascularized, and the tumor itself has shrunk down, with this margin just being associated with Y90 or SIRT hyperemia. So when we take a look at our treatments, you can see that we really incorporate SIRT into our clinical practice in situations where tumors are either very large or very aggressive. We still continue to use DEB-TACE and CTACE. However, those are reserved for patients with good hepatic reserve that we know we do not have a complete curative intent. In those patients that have very large tumors that require significant shrinkage for cure, and by cure, I mean those patients that may potentially have surgical resectability, consolidation to ablation, or transplant, we use SIRT therapy as a first line. In those patients with very large tumors, if we can shrink them down to an ablation target, based on the literature and based on our experience, we then proceed with microwave ablation. We do microwave ablation under what's, in most cases, under a freehand technique. In other words, we don't use CT, we use ultrasound towing, and we actually do central periportal nerve root blocks in order to perform these procedures on an outpatient basis. So we are really trying to do as much as we can to get the patients to go home on the same day, even when we're doing curative intent. So I hope that based on this conversation and the presentation of my discussion today, that you can appreciate that SIRT therapy can expand indications of your embolization practice. It can expand the time to progression. In other words, these patients don't have to come back as often as with TACE. And we've investigated this and noted that our time to progression with SIRT is 4 times longer. In other words, patients will have to receive 4 DEB-TACEs to be equivalent to 1 SIRT in terms of the number of treatments over a course of time. SIRT has significantly lower toxicity, so we also offer this to patients that are older or have comorbid conditions that may complicate their treatment. SIRT, because of the way it works, penetrating into the tumor, being very, very small, increases the chances to surgery or ablation or transplantation. I hope that you've also been able to appreciate that this technique of radiation segmentectomy and lobectomy are unique to SIRT and provide another ablation option for those patients with poorly defined tumors or complex locations of tumors that you may not be able to perform effective percutaneous or laparoscopic ablation on. And further, SIRT improves survival in patients with PVTT not only from a decrease in size for your surgeons to be able to operate, but also from overall survival when using the radiation lobectomy technique. One last point I'd like to bring up, although we did not go into the fine details of SIRT therapy, due to the principle of SIRT therapy, lesions of greater than 6 centimeters are difficult to cure with SIRT. We can shrink them down, but it's difficult to cure. In these cases, the radiographic response results in a significant shrinking of the tumors. Many of them will get below 4 centimeters. And in which case, when we have that type of consolidation, regardless of whether we see vascularity or evidence of tumor recurrence in those lesions of greater than 6 centimeters, we then consolidate into an ablation or surgical intent. If the lesion is less than 4.5 centimeters, we can use microwave. If it's less than 3 centimeters, we can use RFA, and less than 1 in HCC, we may use percutaneous ethanol injection. However, as many of you know, the anatomy will dictate which technology will apply due to many of the details that Professor Gu had described. Thank you very much for your attention, and I hope that this offers you a good introduction to SIRT therapy and how it may extend the applications of embolization in HCC.